Welcome back, everybody, to the second installment. This talk, I am going to say something about the current treatments that we have available for osteoarthritis and where I think the future treatments will come from. And I do think things have changed a lot in the past few years. I'll reiterate that I have a few disclosures which relate to the Step Up OA consortium grant, which I showed you in the previous talk. Okay, so what do we have at the moment? Well, unfortunately, we have really very little for osteoarthritis. And this was a headline taken from the Times newspaper in the UK a couple of years ago, in which it said, if you've got osteoarthritis, you should stop taking painkillers for arthritis, and you should just do exercise. And it could save the NHS billions of pounds. Now, that was a really, really depressing and pretty irresponsible message to give to our patients with osteoarthritis. And it was as a result of a consultation exercise, which comes from NICE, which is the National Institute for Clinical Guidance in all treatments that are recommended by the NHS. So they go through this process and they look at cost effectiveness of treatments and decide whether or not they should be recommended on the NHS. And the problem with most of what we had is that there are very few good randomized controlled trials that have really assessed the quality of some of the things that we do in the clinic. The only ones that really exist are for exercise, and even then there are only 125 randomized controlled trials. There are a few, but very small numbers of low quality weight loss trials. Of course, these things are very difficult to blind, and therefore they're not good quality studies on the whole, even though the intention is usually very good indeed. And the upshot of this analysis is that weight loss is good for osteoarthritis. Exercise is good for osteoarthritis. The more weight loss and the more exercise, the better the effect. Then they also suggested that UK physicians could consider topical nonsteroidals and could consider intra-articular steroid injection, but should not offer even simple analgesia such as paracetamol or gentle opioids, glucosamine, hyaluronan, acupuncture. These are not recommended and not deemed to be cost effective on the NHS. So there are some quite nice clinical trials that have looked at exercise and weight loss in combination. But again, I stress these are really difficult to control. So in this study, they looked at a combination, or either separately or a combination of weight loss and exercise. They showed that if you put the two together, you get an additive improvement in pain response in patients with established osteoarthritis. I think one of the reasons for showing you this study, firstly, you need really big numbers in osteoarthritis trials to see differences, and you'll see that again and again in the studies I'm going to show you. This was really intensive, supervised exercise, meal replacement. You don't get as intensive as that in most of the studies that we are looking at, and it's certainly not pragmatic to do those things often in clinical practice. But one of the things that I think is a really important take-home message that I use regularly when I speak to patients in the clinic is that if you want to lose weight, just doing more exercise is not sufficient. And the excuse often, and I don't mean this unkindly, but the excuse often is, well, I can't exercise because I've got pain, which is understandable. But what this study shows, as others have done, is that dietary change is the most important link to reduction in weight, not exercise. If you put the two together, you get an additive response, but 80% of weight loss is down to diet. And that is important to remind our patients. Okay, so I showed you this before, that a number of different anti-inflammatory approaches, repurposing rheumatoid arthritis drugs, have been tried and failed in rheumatoid arthritis. But it's probably not to say that this is the only message, because there have been some recent clinical trials that have shown small effect sizes in selective groups of individuals with osteoarthritis. And here is one of them. This is a study called Methods, which is methotrexate in inflammatory hand osteoarthritis. So these were selected for having synovitis. This was published recently, And it shows that there is a statistically significant decrease in pain and function in those individuals who have hand OA, who are on methotrexate, but not on the placebo. It is a very small difference. It just met the clinically meaningful difference in patients, but I would not say that this is something to really raise your hat on, because this is still a small effect for a drug that we know is associated with lots of side effects, but that's something to consider. We also know if you give a moderate dose of oral steroids, this is 10 milligrams of prednisolone, 5 milligrams has been tried previously and has failed. And this shows that there is also a transient effect of steroid, a slightly bigger response, but again, it's not massive. But the important thing is that this immediately goes back to pre-pain levels as soon as you stop taking the drug. We cannot be giving 10 milligrams of prednisolone to our perimenopausal women with hand OA. It would not be in their best interest. It would cause osteoporosis and all sorts of other side effects associated with steroids. So this was a proof of concept study, but I'm not actually sure what it's really proving in terms of what we can help our patients with. Now, we do use steroid. This is one of the newer clinical studies looking at one of the slower release intra-articular steroid preparations. It just failed to meet its primary endpoint at 12 weeks, but you can see convincingly that there is at least a steroid response initially, which is superior to placebo, which you see in these open circles above here. But it wouldn't be true to say that this is a very prolonged response. You probably see it just beyond that 12 weeks, but not really beyond that. And if you compare it with the ordinary standard triamcinolone type preparations, intra-articular injections, you see some slight superiority, but it's very similar to what you would see with other steroid preparations. Now, that's all very well, and sometimes we give this to our patients. There's a big placebo response, so some of them are happy with that, and they do get some temporary relief. But this was a really important study, and this was looking at what happens if you give repeated dose of steroid intra-articularly every 3 months for 2 years. And this was an important study to do, because not only did it show that if you actually look at that 3-month period, so just prior to giving the next injection, the patient was asked about their symptoms. Turns out that their symptoms are identical to the placebo at the 3-month time point. They might have had a transient improvement, but it had already gone back to baseline by then. And that was true across pain, across function, across all the different metrics they looked at. But really importantly, they also MRI scanned these individuals and showed that in the ones receiving regular steroid treatment, you actually got a further reduction in the joint space. So in other words, there was worsening of the articular cartilage loss. And so this really does need to be taken into consideration when we're thinking about giving steroid injections to patients with osteoarthritis. My own personal practice is that I do it quite a lot in hand osteoarthritis, where patients appear to get a benefit that is sufficient for them to be able to do their exercises. And that is really important to keep the mobility of the joint, because hand osteoarthritis tends to have a more burnt out progression. But I'm not very keen on giving it to large joint osteoarthritis. Okay, those are the sort of what we have available and what has perhaps worked a bit and that we might be using anecdotally in our clinics. What about the things that haven't yet got into clinic? And this is probably the biggest story in osteoarthritis in the past 10 years. This was looking at neutralizing nerve growth factor. And nerve growth factor is a phenomenal target for pain in osteoarthritis. We showed that in the mice. This was also demonstrated in humans. Our papers came out in the same year, and this is the effect. So this was the first clinical trial using tanezumab. This is an anti-nerve growth factor antibody, 2 injections given 8 weeks apart, showing a really, really strong dose-dependent reduction in pain in patients with knee osteoarthritis. And this is so much bigger than any other drug we have seen thus far, much bigger than opioids, the non-steroidal anti-inflammatory drugs, much bigger than the steroid responses we've just seen. Unfortunately, there have been problems with it. The FDA halted the trials momentarily because they were concerned about rapidly progressive osteoarthritis in a subset of patients. The phase 3 studies continued with extra vigilance. The bottom line was that 8% of individuals taking these treatments did actually develop rapidly progressive osteoarthritis. And when Pfizer Lilly put in their application to the FDA to license tanezumab for patients with painful knee osteoarthritis or painful osteoarthritis, the FDA rejected this on the basis that there was still an unhappy making 8% of individuals who had rapidly progressive osteoarthritis, despite them reducing the dose. So the actual effective analgesic dose that they were giving was also not really giving such a huge benefit to the patients. So this has been an enormous disappointment in the field, but it nonetheless means that it is possible to target this pain in osteoarthritis, and it's really quite distinct from the type of pain that is associated with other inflammatory conditions. So that's the disappointing news. I want to now be a bit more optimistic and tell you some of the positive things that I think are going to arise in osteoarthritis. I've already shown you that osteoarthritis is driven by mechanical load, and therefore it is of no surprise that one of the big stories of the past year is that the STEP 9 trial of semaglutide, so this is one of the GLP agonists, this is one of the big weight loss drugs, has had a really strong pain response in patients with knee osteoarthritis. They took their time to look at OA as a primary disease indication for their weight loss drugs. We've been waiting patiently, going, why haven't you done OA yet? They looked at pre-diabetes, diabetes, cardiovascular disease, but I'm really pleased to say that they've now got osteoarthritis firmly on their radar. And this shows that if you give a standard weight loss regimen to patients with painful knee osteoarthritis with high BMI, these BMIs, I think, were over 35, or at least certainly over 30 if there were other indications for giving it, then you can see that there is a nice reduction in pain response. It's in pain. It is not as big as anti-nerve growth factor, but it is still diverging, and that's after 52 weeks of treatment. And I think this is really very, very promising news. So I think we're going to see a lot more on that. And that's good because you're not just curing pain at the risk of worsening your mechanical damage, you're also offloading the joint a bit. So hopefully that increased risk of damage when you haven't got so much pain is less likely to be evident. Okay, so that's the first bit of good news. Now, the second bit is that I've told you already about these pathways, about this repair pathway. I've told you that genetics is associated with a lot of repair genes. And so the question is, can we really target pain in osteoarthritis? And you may say to me, well, it's all very well saying that you can do this joint distraction procedure, but is this really realistic in our patients? Is this really going to be done? I would say possibly. We've tried to do clinical trials in the UK. They failed to recruit. It was partly because it was in the middle of the pandemic, which was a real shame. I would like to see more of these studies going on. But the really reassuring thing is that in a smallish study that was done in the Netherlands, they were able to show that there is equivalence in terms of the response, or very near equivalence, to how patients respond to knee joint distraction compared with total knee arthroplasty. And on the basis of this and other studies, the Dutch government have actually, and I think also Rheumatology, which is their charity that looks after arthritis in the Netherlands, has just funded a really large randomized controlled trial in which they're looking at 1,200 participants and comparing knee joint distraction with total knee arthroplasty with MRI follow-up at 2 years. This is called the Godiva study. And so we're going to hear much more about this. And if there are surgeons amongst you and you're not already doing joint distraction, and you may already be doing it, but I would seriously look at the results of these studies. I think they're very exciting, and it's a much less invasive. It looks invasive, but it's much less invasive than doing a joint replacement, particularly in slightly younger individuals, which is what this study will be in. Okay, so you could do this mechanical offloading, and that seems to allow that natural repair of the cartilage to occur. But can you actually try to promote that repair just by using pharmacological agents? And that is, of course, an important area that also needs to be considered. And so this is one such agent that might be able to deliver such promise. This is a study which was called the Forward study, and this was injecting growth factor into the joints of individuals with established knee osteoarthritis. And the growth factor that they injected was something called sprifermin, which was an analog of one of the FGF family. So it's fibroblast growth factor 18, which is very similar to FGF2, which is the growth factor that we find being released from cartilage in response to injury. FGF18 and its receptor, FGF receptor 3, were both GWAS hits, so they were both genetic hits and were on that list that I showed you earlier. This study actually predated the genetic study, so this came before based on preclinical data and other data, but showing that there is pro-regenerative activities of this molecule within at least animal models of arthritis. So this was a large, again, over 500 patients study looking at different doses of injecting this slow release FGF18 into the joint, either at a lower dose, 12 monthly, 6 monthly, or at a higher dose, 12 monthly or 6 monthly. And what you can see in this is a secondary analysis, but this is a thickening to thinning ratio of the cartilage as assessed by MRI. What is evident here is that there is a really nice dose-dependent increase in this thickening of the articular cartilage in response and in those individuals receiving the higher dose of sprifermin at the more frequent delivery. And so this is the first time that we've really seen a pharmacological agent that's able to recapitulate that growth of the articular cartilage. Now, another disaster befell this study because what happened next was really very disappointing, which is Merck Serono, who owned the asset and who did this study, decided to sell it and to abandon doing osteoarthritis research completely. And why did they do that? And that is because when they looked at their secondary endpoint in the study, which was pain, they did not see any improvement over the placebo. And because the FDA requires both pain and structure to get licensing approved for a disease-modifying drug, they didn't think it was worth pursuing. Now, pain is notoriously difficult to measure within osteoarthritis trials. Pain is very subjective, obviously. It is influenced by so many other external factors, not just what's going on in the joint. And also, of course, it may lag behind repair of the articular cartilage. But the other problem that you have with pain is that pain does not correlate very well with structural disease. And if you recruit a very broad range of osteoarthritis patients who have early disease and late disease and very high pain levels and very low pain levels, you really struggle to see differences in a response. Now, in a post hoc analysis, a group decided to, rather than look at the intention to treat population, to look at a subgroup at risk. And these were individuals who were at risk of disease progression. So remember that within a standard OA population, only about 30% of individuals will actually progress with their osteoarthritis over a trial period. In fact, most patients stay really quite stable. So being able to see a difference in those individuals is very hard to do. And so if you enrich for the subgroup who were predicted to progress, and those were individuals who had more severe disease at the beginning, who had higher pain scores at the beginning, and you only look at those, then you do see a difference between your placebo and your highest dose of the sprifermin. So although that's a post hoc analysis, it does rather suggest that with the right type of clinical trial design, you may be able to actually see both structure and pain improve in patients with these pro-regenerative therapies. So we're waiting to see what happens next. There is a smaller company that has taken the asset, and we're hoping that they will do something with it, and that will result in patient benefit. Okay, so what other pharmacological agents are pro-regenerative on the horizon? Well, the other couple that you may have heard about, and certainly you may hear more about, are an agent from Novartis called LNA043. This was picked out of a screen for things that promote chondrogenesis, so promote the differentiation of cartilage in vitro. This turns out to be an angiopoietin-like agonist. And it has very strong preclinical data that was published in Nature Medicine a couple of years. It's been designated already fast track status by the FDA. There have been a number of randomized controlled trials that have already been set up, including one in combination with anti-IL-1. And these will report in due course. And I have no idea what that is going to show, but we're keeping our fingers crossed. And the other one is loracivivint, which is a little bit further down the line. There have now been phase 3 clinical studies looking at this Wnt inhibitor. Again, you perhaps missed it, but Wints are also come up in GWAS. They're on that left-hand side of the panel. They're associated with cartilage repair and this promoting chondrogenesis phenotype, which is what you need to repair your cartilage. And they're very complex, so you sometimes need to inhibit and sometimes need to promote it, the pathway. And we hopefully will hear more about these, but we think there may be an application to the FDA to try and get these licensed in osteoarthritis. Okay, so that's the pro-regenerative therapies. Very quickly now, I'll just talk about whether we can target those mechano-inflammatory pathways. I said I'd come back to talk about this one gene. This is a gene called ALDH1A2. It was identified by the Icelandic group a few years ago, 2014. They showed that it was one of the few very strong GWAS hits in hand osteoarthritis specifically. These variants are very common in the population, present in about 50% of the population, and it has quite a high odds ratio for association with increased risk of osteoarthritis. The variant itself predicts lower levels of this gene associated with higher levels of osteoarthritis. Why is it interesting? Well, it is the key rate-limiting enzyme in the synthesis of something called retinoic acid or all-trans retinoic acid, which is a known anti-inflammatory agent, very highly expressed in chondrocytes. And this retinoic acid is controlled both by its synthesis and also by its breakdown by an enzyme called CYP26. And what I'm going to show you in a moment relates to this drug called telarizol, which can inhibit the breakdown of retinoic acid, and thus it can boost retinoic acid in the cell, thus promoting its anti-inflammatory effect. If you're interested to hear and read all about the science, then that was published in this paper in 2022. And this was validated through multiple different species, including putting it into a mouse model of osteoarthritis. And the summary of this study is that when you trigger mechanoinflammation, you not only trigger this reduction, this activation of the inflammatory pathways and inflammatory genes that drive cartilage degradation and pain, but you also trigger a drop in retinoic acid. And because retinoic acid is normally anti-inflammatory, that drop in retinoic acid amplifies the inflammatory response. If you put telarizol into the system, or you feed mice or deliver mice telarizol, you can suppress that drop. In other words, you maintain that anti-inflammatory tone, and therefore you suppress this inflammatory response. And why this is important, well, telarizol has been used in phase 2 clinical trials for other indications in the past. So we have been able to take this drug and give it to patients who have hand osteoarthritis. This is an ongoing experimental medicine study in which we're planning to recruit just 34 patients who are on a surgical waiting list to have their trapezium removed for bad base of thumb osteoarthritis. And they will be randomized into receiving either telarizol for 2 weeks or placebo for 2 weeks just prior to their surgical date. and they will then, at the time of surgery, have the tissue analysed to see whether or not that drug has got into the tissue and has suppressed those mechano-inflammatory genes in a way that we anticipate. And we think that this will be really important to confirm target engagement and also to consider how we would power a subsequent clinical trial. So we're very excited by that, and hopefully we will be able to progress that further. Okay, so I'm going to just finish off by saying we are likely to see, I think, more pro-regenerative agents coming onto the market, being licensed for osteoarthritis treatments. I personally think that structural disease modification will probably lead to involvement in symptoms, but we need to design our trials appropriately to be able to test that. And we probably need to wait long enough in order to be able to see that. So we shouldn't be impatient. And I also think that any of these approaches where we can link hits that come from human GWAS into drug development is much more likely to succeed. We know that from a number of other studies, not just in osteoarthritis. So with that, I'd like to thank you all for listening, thank my group again, the broader Centre for Osteoarthritis Pathogenesis, not just within Oxford, but also my colleagues in other universities nationally. And again, thank you all very much for listening, and I look forward to a lively discussion.